Hi, and welcome to the next broadcast, or this broadcast, of the Rheumatology Nurse Practice Google Hangout series. My name is Kevin Lyons. I'm the Executive Director of the Rheumatology Nurses Society, and would like to welcome you today as we do a very fast run-through of some challenging cases in rheumatology. Our faculty today is Linda Grinnell-Merrick. She is our incoming president of the RNS, as well as Carrie Beach, who is our historian for the RNS. There's three ways to ask questions if you would like to participate. First, you can type this link into your browser, and I will just let you look at that link. This is a pretty long one. It's goo.gl/slides/BU78SR. You can also use a hashtag RMP17 on Twitter, and you can also text your questions to the Google Voice text line to send in the question. That's 267-689-8495, 267-689-8495. With the Rheumatology Nurse Practice Initiative, we have live dinner programs. We also have Google Hangout broadcasts, just like the one you're currently watching, as well as our Rheumatology Nurse Practice peer-reviewed publication, which is mailed to thousands of healthcare professionals in rheumatology and primary care across the country. If you don't have this one in your mailbox, this is our latest edition, but if you don't get this, go to our website, rnsnurse.org, click on Education in Rheumatology Nurse Practice, and you can sign up to receive these for free. In the current edition of the RMP that just launched, it's making sense of an increasingly complex treatment paradigm in RA. And there's many great objectives inside, like why are there so many recommendations included within consensus guidelines based upon low or very low quality of evidence? What are some of the key overarching principles of the 2015 ACR, American College of Rheumatology guideline for the treatment of RA? And what recommendations have been made specific to patients with common comorbid conditions? There's a lot of great information in there, great writing up front, some great science, and then we also get into nursing anecdotes in the back, which is a lot of clinical pearls of wisdom that's tied into it. So we'd like to start today with our faculty, Carrie Beach, as she shares today's case.
Thanks, Kevin. So our case today that we're going to talk about was a patient that came into our practice. He is a 60-year-old male, presented to our office for the first time with sudden onset pain that had begun in his legs about 5 weeks ago, then migrated to shoulders, and since then have progressively worsened. He stated that 1 week ago he woke up in the middle of the night barely able to walk due to severe muscle weakness and cramping in his bilateral legs. He said he couldn't even walk down the hall. He tried to get out of bed and couldn't even walk down the hall. So his wife took him to the local emergency department, where surprisingly to me there was no diagnostic testing performed, no labs, no x-rays. Offered him pain medication, but he refused. He already had a prescription of hydrocodone that he had taken as needed for back pain. He did have a prior back surgery that he had that prescription for. So they sent him home. He tried 800 milligrams of ibuprofen and a hydrocodone daily. He did that for probably another week. Still wasn't getting any better. And so he went to his PCP, and this was 2 days prior to when he got into our office. PCP gave him cyclobenzaprine and kind of sent him on his merry way. Obviously, he didn't have much improvement, so he actually had to call his PCP back and ask for a referral to rheumatology. He said he felt something was wrong and wanted to get it checked out. Prior medical history for this gentleman: left knee arthroscopy in '96 and again in 2012. He did have a lumbar spine surgery in 2001, hypertensive, hyperlipidemia, otherwise very healthy, working every day, full-time, very active. He states that he exercises every day, lifts weights daily, prior to obviously the symptom onset. So current medications he's taking: he takes lisinopril 10 milligrams a day for his hypertension. He started on vitamin D 2,000 IUs a day, simvastatin 40 milligrams a day, tamsulosin 0.4 milligrams a day, the hydrocodone, acetaminophen 5-325. He was doing one daily on that. And then the PCP had prescribed cyclobenzaprine 5 milligrams, one 3 times a day as needed. He was taking ibuprofen 800 milligrams 3 times a day, and also omeprazole 20 milligrams. So, Ms. Linda, what would you suspect is going on with our patient?
Well, it's interesting because a lot of stuff is kind of coming to mind right away. You're kind of thinking, okay, you know, what's going on? Is this joints or is this muscle? So, you know, I'm anxious to actually get my hands on him so I can kind of do an exam because, you know, then looking at his meds in his past history, you know, is this related to osteoarthritis? Because we know he's got osteoarthritis. He's had knee replacements in the past. Then looking at his meds and getting a little concerned. I'm going, okay, he's also on his statin, so could there be some kind of myopathy going on related to his statin use? It could be an infection, you know, I kind of need to get a good history on him. Is there some kind of an infectious process going on that's contributing to this? So lots of ideas. An injury, you know, I see he lifts weights, you know, Is it possible he's got, you know, rotary, you know, rotator cuff injury or something else like that going on? Did he overdo it? Is it fibromyalgia? You know, kind of sudden onset, but there's some new stressors or something that's gone on in his life. And then because I live up in New York State, I'm going to bring it up, is it Lyme disease, right? Has he been out in the woods or whatever? So that was just a thought that I kind of would pop into my mind because of the area that we're living in currently, that I'm living in.
Yeah, we have a lot of patients come in, you know, asking for Lyme disease testing. It's not so popular here in Ohio, but we do see it. So.
Yeah, I think almost all our patients are asking us for that, but it's a little bit more prevalent right here in this area in upstate New York.
Right. Okay. So what would your next step be in figuring out?
As I said, my next steps, I'm anxious to get my hands on him and do a really good physical, you know, checking out the joints. Are they swollen? Are they tender? And his muscles too, you know, and is any muscular weakness, anything else going on, and trying to get a good history on him. You know, what's been going on? What's your family history? Any recent stressors? Anything different? Any infections? Even thinking about, you know, an arthritis related to inflammatory bowel disease. You know, is there a history of Crohn's disease, a history of ulcerative colitis? So those types of things would be my next step, a good physical, a good history. From there, moving on to labs and getting some labs. And maybe imaging, but I think it all depends pretty much on what he's telling me and what I'm feeling during the history as to whether or not I'm going to imaging.
Right, and he had actually contacted his surgeon that did his spinal surgery, let him know the symptoms, and he didn't have him come in. They didn't do any imaging, but he told him he didn't think it was consistent with, you know, his prior surgery or anything. So we kind of ruled that out.
You know, he's feeling awful if he's calling his surgeon, right?
Right, yeah. he called everybody. Poor guy. I mean, nicest man. You could tell he was still going to work every single day. His wife's like, I have to practically help him get dressed, and it's surprising how suddenly it came on for him.
Yeah, you know.
So, well, what we did, if we move on. Okay. So immediately, obviously, we discontinued his simvastatin. He had been on it. I looked back in his history. He'd been on it since October, and he saw us like April. So he had been on it for 6 months at that point. We started him on a prednisone taper. Started off at 30 milligrams a day and tapered by 5 milligrams every 5 days, and then scheduled a follow-up for 4 weeks. Also did a comprehensive panel of labs. So we did an ANA screen, CBC with DIF, a comprehensive metabolic panel, CPK, CRP, sed rate, a myositis panel, thyroid TSH, and rechecked his vitamin D. So results came in about a week later. His ANA was positive 1 to 40. CRP was at 9. CPK was at 150. Sed rate was 96. Myositis panel negative, and all of his other labs were within normal limits or unremarkable. So I called the patient with his lab results a week after we had seen him. Told him we were leaning towards a diagnosis of the polymyalgia rheumatica, or PMR, which he was completely baffled. He said he was feeling much better since starting on the 30 milligrams of prednisone, which he was actually still, I think he had dropped to 25 when I talked to him, but he was still doing much, much better. So we told him to call the office if symptoms worsened and keep his follow-up for 3 weeks. So how, if at all, might you have handled this patient any differently?
I think you guys did it all. There isn't too much else that we could have done. I think the only other thing that came to mind in reviewing the case is we do know that giant cell arteritis is frequently associated with PMR. So, maybe, but those questions were probably already, because we don't know exactly what took place during the physical exam.
Right.
My guess is that whoever saw the patient, the provider that saw the patient probably asked the questions about visual disturbances, headaches, tenderness along the scalp or something. And that's just one of my frequent things when I'm trying to rule out PMRs, then you start worrying about giant cell arteritis. But that probably been my only other thing that I wanted to add, that so that we're all kind of keep that in mind when we see these patients with PMR, also to keep that in mind.
Right. And I think what caught my provider kind of off guard was she thought he was 60 years old, which we can see patients with PMR, but typically, we see them older at the time of onset. So do you see a lot that are under 70, I would say?
Yeah, interestingly, I've had people in their 50s, late 50s, who've developed this. Again, that's not a large population of people, and it's usually these people that, maybe their SED rates aren't crazy high, maybe just borderline elevated, and horrible fatigue and difficulty getting going in the morning. And, so we've tried the steroids and we've done the prednisone. It seems to work for them. So I always feel that we see the patients. I think there may be more people that, my train of thought here for a second, is that there are more people that might be in their under 60 or in their 60s that have this, but maybe they're being treated by their primaries well, and we're not getting them. So I think lots of times we in rheumatology get them when they're a lot, harder for the patients to manage, or, not getting into remission and not doing well on the prednisone, and then they're coming to us.
Interestingly, the patient's the one who requested the referral to rheumatology. So I don't think the PCP even had it in his line of thinking that he
wasn't even in his radar.
It was not at all in his radar, which I guess it doesn't really surprise me, but
it doesn't.
No, we see it all too often.
I think if he was a little older,
yeah,
perhaps that would have been in somebody's radar, but at that age, probably just didn't even think about it. And it's kind of sad. They kind of dismissed him without doing any workup at all.
Well, and I thought nobody did. ED didn't do labs, PCP, nothing. That was really surprising to me that we were the first ones to actually do lab work on this poor guy. For as severe as his symptoms were, it wasn't like he was coming in with a little bit of back pain or a little bit of, weakness and pain. He was in bad shape.
Yeah, that's really sad. I'm surprised that somebody didn't even just try a steroid taper, whether it was in the ED or they offered him narcotics instead, which is fine, but and didn't even usually we see. Not usually, but lots of times, for any number of ailments, patients will come in, they've already been put on a large dose of steroids, and then we're kind of trying to figure out, okay, well, and then we're backpedaling to kind of figure out what's really going on, because they're feeling better when we see them.
Right. That makes it difficult because it works so quickly.
Right. So but this was interesting. This poor guy, he went quite a while without anybody checking labs or giving him anything except for a muscle relaxant.
Right.
So I
And
feel
he
bad
went
for
to
him.
August in 2 days, which right now our wait list is like, I mean, it's about 3 months to get in to see
Oh
one
my
of our
goodness.
docs. So I don't, he was just, he was very lucky. I don't know how he got in so quickly, but it was good timing. So
Yeah, I'm happy for him.
yeah, he is doing much better. And then the 30 milligrams prednisone, is
Yeah.
there a dose you typically start patients
We'll
on?
start between 25 and 30 milligrams generally,
Okay.
and then just do a very slow taper, which I'm sure what you guys are doing. We
Yeah.
frequently see when patients are coming in, I think, who relapse frequently, it's because they're probably doing the taper a little bit too quickly out in, in the primary care setting. That's because lots of times people, have a fear of prednisone. You're putting me on steroids. What's going to happen to me?
Right.
Even though they're feeling really well, and especially when
great.
they're feeling well, they're anxious to get off the prednisone. But yeah, typically that's where we would start, either 25 or 30 milligrams. Give them a slow taper, do just exactly what you guys are doing, check in with them, then have them come back in a short amount of time. Now, will you be repeating labs next time he comes back to check his blood rate and
check
see
his blood rate, make sure it's coming down. Right.
Good. Yeah, and that's exactly what we would be doing.
Okay. Well, I think it's pretty consistent. And I know the ACR has guidelines. Their 2015 guidelines are, I read through those today. They're pretty well what we followed. So, and then methotrexate, when do you guys consider adding that? I mean, I know this gentleman isn't anywhere near, we don't have to think about that at this point, but we do have several patients that we do have to start on methotrexate.
Right. And we do too. We have several patients. Those are usually the ones who continue to relapse, or we just can't get them off steroids. And for numerous reasons, need them off of steroids, that they are older, their risk of fractures, if they haven't already fractured, is so high. So you're really looking at trying to spare them the steroids and all the other side effects, that they can get with the steroids. So we do use methotrexate with those patients a fair amount of time. But again, they're usually the tougher cases that we're seeing and the people that just had a really hard time, a long course of steroids and having difficulty trying to get off of them. Then we'll introduce methotrexate and slowly then continue to try to taper off the prednisone as they get methotrexate on board.
Yep, that's how we manage them as well. And then biphosphonates, I asked, when you would consider adding that.
Yeah, and that's interesting. Something I really had to stop and think about, because I feel, if anybody's watching from my office, I'm sorry that we're maybe not that good about considering that. Usually it'll be a few months after they've been on the steroids, or at least with us, if they've already come to us and been on it for a few months. I like to get a baseline DEXA. To see where they're at, especially if they haven't had, and this is a male in his 60s. My guess is he's not had a DEXA, because that's not going to be in anybody's radar at that point, to see where they're at, and then kind of wait and kind of gauge how long, is he tapering off the steroids okay? Are we doing well, or does this look like it's going to be a long, like you said, the guidelines that are out by ACR and EULAR, it can take 1 to 2 years sometimes for people to actually, get through the treatment and get into a full remission. So certainly would be looking then, do we need to consider adding something? And at the very least is, this guy's very active, but making certain they're doing some, they're staying active, and that they're doing their calcium and their vitamin D along with this. So definitely something I'm going to keep in the back of my mind a lot more after reviewing this case.
Good. Well, thank you, Miss Linda.
Well, thank you, Carrie. It was a very interesting case. I think we see a lot of PMR. Enough of it, I shouldn't say a lot, enough of it that it's something we have to always keep in our differential diagnosis when these patients come into us.
Right.
Thank you, Carrie.
Thank you.
Awesome. Thank you so much, Linda and Carrie. A very fascinating GCA case for sure. We also would like to thank everyone who watched today. A very important thing coming up in August 9 through 12 in Orlando, Florida is the 10th annual conference of the Rheumatology Nurses Society. We definitely want to sign up sooner than later. We have a price increase coming up here in about a week or two as far as the registration. So we'd love to have you. You can also fill out an abstract or submit an abstract and be selected for posters. We have a lot of just great activities this year at the conference. It's going to be something very, very special for you as we celebrate our 10th anniversary. Our next broadcast of Rheumatology Nurse Practice is going to be on Wednesday, July 12th at noon. And that's Wednesday, July 12th at noon. And then also, of course, for up-to-date information on the Rheumatology Nurse Practice Initiative, visit us on our Facebook page, or you can also go to our website, rnsnurse.org/RNP. So we'd like to thank you again for joining us. All of the RNP, the Rheumatology Nurse Practice videos that we record are available on the RNS website for replay. And we'd invite you to take a look at those as well as all the back issues of Rheumatology Nurse Practice. Linda, Carrie, do you have any closing comments?
Nope. Come to the conference is all I want to say. Sign up now.
That's right.
10th
Awesome.
anniversary. It's going to be fun.
It's going to be awesome. Well, thank you so much. Thank you, Linda, Carrie. Thank you, Scott, our partner in the RMP process. I keep saying RMP, that's Rheumatology Nurse Practice. We're a world full of acronyms here. Thank you all and have a great day.